We start with a program of Guru Vidya, which is respecting and honoring our teachers for what they have given us and to share the knowledge which they have given us with all of you. The object of this program is to reach out to interiors of Maharashtra in every district of Maharashtra so that the doctors in interiors can improve on their patient care and have better outcomes of patients. Uh, as we are not able to reach out individually to doctors, we thought this is a better use of technology to reach out so that they can help their patients and improve patient outcomes. Today's topic on Guru Vidya is systolic heart failure. Let me begin this talk on systolic heart failure by giving an example of a patient. Now, if a patient comes to you with breathlessness, it is always a dilemma to diagnose the etiology and cause of this breathlessness. This breathlessness could be because of either a respiratory problem, which could be an asthmatic problem, or it could be a cardiac asthma, where the etiology is cardiac, or it can be because of pulmonary embolism, where a large embolism has gone and obstructed the pulmonary artery and the patient develops breathlessness, or it can be because of systemic infection, septicemia, and patient going into ARDS. So there is always a dilemma right from general practitioner's level to a tertiary care specialist like a cardiologist or even a chest physician. So I think the first thing which should be done when a patient comes to you with breathlessness is to take a proper history. Whether the patient has had the symptoms since childhood, in which case then it will go more in favor of an asthmatic problem. Let us try to see how do you differentiate the presentation of a patient with bronchial asthma with that of a cardiac asthma. Generally, a bronchial asthma would occur more in the early hours of the day. That is when the pollutants settle down and the allergens can precipitate problem. Whereas the cardiac asthma will occur maybe 2 or 3 hours after meals, after the patient has had his heavy meal and then gone to bed. The patient can present you with breathlessness late, maybe around 1 o'clock, 2 o'clock at night. That is number one. The number two is in case of a bronchial asthma, the patient would have previous history of repeated episodes of asthma and history of taking drugs in the past. A cardiac asthma would not have a history of breathlessness in the past unless he's had one episode, one or maybe 2 episodes of LVF in the past following ischemic heart disease. Then you would come to know from the history the pattern of drugs that the patient is taking. If the patient is taking inhalers or if he's taking bronchodilators, then it is likely to be a respiratory bronchial asthma. But if the patient is taking vasodilators or if he's taking ACE inhibitors, then you know that probably it is cardiac asthma. The family history, if the patient has history of bronchial asthma in the past family, then it's more likely that patient can have bronchial asthma. Whereas a cardiac asthma, patient would have history, relatives would have history of ischemic disease. So it is very important to differentiate on history whether the patient has got a bronchial asthma or a cardiac asthma. And more important is clinically when you examine the patient. In case of bronchial asthma, there will be a prolonged inspiration and a prolonged expiration. Plus, the accessory muscles of respiration will be very prominent. In case of cardiac asthma, the respiratory rate would be rapid, shallow respiration, fast inspiration, fast expiration. And if you examine the patients with bronchial asthma, either it could be a silent chest or you could have a lot of wheezing. Whereas in case of a cardiac asthma, the patient is likely to have maybe on examination, you may have a heart which is dilated, and on auscultation, you may find either a murmur or a gallop. So this is very important for you to differentiate. In fact, the most important presenting feature in patient with breathlessness could be either a bronchial asthma or a cardiac asthma. Rarely you may have a patient presenting to you with pulmonary edema, or it could be a sepsis which is presenting to you with respiratory distress. So when these patient presents to you with this symptoms, number one is first try to find out the etiology and the cause of breathlessness. Second, in this patients, very important. I think any patient with breathlessness, you should do this investigation as a routine. Number one is drop eye. Drop eye will tell drop eye will tell us about there may be a ischemic episode and whether it's the etiology is cardiac or not. Second is NT-proBNP. It's a very important marker of cardiac asthma. And if NT-proBNP is elevated, that will tell us that this is a marker for cardiac problem. The third is a D-dimer test. D-dimer, if elevated, tells us that there's a great probability of a pulmonary embolism. And the fourth is HSCRP. If HSCRP is elevated, it tells us that this patient is likely to have a systemic infection, which is presenting to you as breathlessness. So please remember that if a patient comes to you with breathlessness, these four investigations form the basis of trying to rule out the etiology of breathlessness. In fact, just last week, I had a patient, this week itself, I had a patient, he's weighing 120 kgs, came to me with breathlessness and cough. Now, in the past, he has undergone an angioplasty twice. So it was very difficult to prove or disprove whether this is a cardiac asthma or a respiratory asthma. And because of his heavy weight, he's got no control over his food habits. So it was difficult, very difficult to ascertain. I did a very simple test. I did his NT-proBNP, and we also did his D-dimer. D-dimer was negative. NT-proBNP, we first did a qualitative test. Qualitative test came positive, but we did the quantitative test, and for a 70, the quantitative report, the NT-proBNP was about 400. Now, in a patient who was 74, NT-proBNP levels of 400 is not elevated. Okay, so we treated him as a case of bronchial asthma, low respiratory infection, gave antibiotics, and within 2 days, he had recovered totally. Then the X-ray showed a small patch. So these are basic investigations which help us in differentiating the etiology, and it aids us in treating these patients on a faster basis. Let us go to what are the etiology, symptoms, and investigation management of patients with heart failure. Okay. What is the definition of heart failure? Heart failure occurs when the heart cannot pump blood efficiently, leading to reduced blood flow and oxygen delivery to the body. And because of this reduction in blood flow, it can result in multiple symptoms. We'll come to that next. The epidemiology, it's a significant public health problem affecting more than 6.2 million Americans, and an equally large number of Indians are also affected, though probably we still don't have a proper figure and data. But in India also, the prevalence of heart failure is fairly large because of aging population and risk factors. Now, what are the risk factors for patients with heart failure? The most common risk factor is coronary artery disease, atherosclerosis, narrowing of the arteries, which can result in ischemia of the heart, of the cardiac muscle, and that can result in heart failure. Hypertension. In fact, in the last 1 week, we had about 3 to 4 patients with severe hypertension presenting to us with breathlessness, and turned out to be that it was a hypertensive heart failure. So, hypertension is a very important risk factor which can result in systolic heart failure. Diabetes, I think all of you know, is a silent killer and is one of the largest cause of cardiovascular disease and heart failure. And also the complications. Diabetes may affect the kidney and therefore result in kidney dysfunction, resulting in hypertension and thereby precipitating a heart failure. In fact, diabetes also affects the small vessels of the heart, and therefore, even if you do an angiogram and we find normal epicardial vessels, you can still be having small vessel disease, and these patients can present to you with heart failure despite having normal coronary arteries. So these are the first more common things. The other etiological factors could be cardiomyopathy. It could be a hypertrophic cardiomyopathy presenting to you with congestive heart failure, or it could be a dilated cardiomyopathy where there could be a genetic transmission and resulting in heart failure. Sometimes infective etiology like viral myocarditis, where the myocardium gets affected badly because of the virus, and this itself can present with heart failure. So there are many other etiologies which can also be responsible. Very simple thing like smoking on a regular basis, that itself causes increased coronary artery disease, increased atherosclerosis, and can present as heart failure. Then alcohol intake. Alcohol intake in moderation amount of 1 to 2 pegs is okay, but excessive alcohol intake can have a toxic effect on the myocardium and thereby result in alcoholic cardiomyopathy. I think another important reason, though not very common, is called as tachycardiomyopathy, where one has a persistent evidence of fast heart rate, supraventricular tachycardia, or SVT with arrhythmia, and a sustained chronic recurrence of tachycardias can result in patient presenting to you with heart failure. So there are multiple etiologies, but most common is hypertension, diabetes, coronary disease.
Petrol.
So these are the various causes which can cause etiology of heart failure. What are the clinical presentations and symptoms of heart failure? Dyspnea is the most important presentation. And as I first discussed for the case, dyspnea, breathlessness, it can come suddenly in case of acute left ventricular failure, or even in case of right ventricular failure, or if the patient got into congestive heart failure, then patient can complain of dyspnea. Extreme level of fatigue can occur because of dilated cardiomyopathy or because of low cardiomyopathy and reduced perfusion to the body. The patient can you mute all of them?
संडे को कल संडे है ना
Disable. There's a reason for muting. Okay, anyway. I think we were talking about fatigue. That is because of low oxygen saturation and low cardiac output that patient can present to you with extreme fatigue. Edema of feet, there's retention of fluid in the legs, retention of fluid in the liver, or generalized sinus sarca can be the presentation of patients with heart failure.
मेरे आने के बाद जाएंगे ना
What are the diagnostic workup for heart failure? As I said, a medical history.
अदनान का भी आना
Can we have our audience keep their computers on mute, please. Okay. So medical history is very important. It helps us to evaluate the etiology of heart failure. Physical examination is another very important thing which tells us towards the diagnosis of heart failure. Edema, edema feet, uh, elevated JVR or a hepatomegaly, tender hepatomegaly would be an indicator of patients with heart failure. Then on clinical examination, if the patient's got cardiomegaly or if he has uh, evidence of a third heart sound, which indicates a left ventricular failure, or patients has bilateral basal creps, this will all go in favor of patient with heart failure. Now, what are the investigations which are available for us? I think the basic would be investigations to find out as to whether there's a ischemic load or burden on the heart. We do the basic CBC, BUN creatinine, HbA1c, then lipid profile, and NT-proBNP is a very important test. Mildly elevated NT-proBNP can be elevated. It can be elevated in a number of causes. Even elderly age group can have a mild elevation of NT-proBNP. So the levels of NT-proBNP need to be really high before you say that this is patients with heart failure. And TROPI also is an indicator that this is an ischemia-induced heart failure. So these are the blood markers for patients with heart failure. Then we can go on to the other investigations like the ECG. ECG is very important. ECG can give us evidence of a whole infarct, or if there's evidence of ischemia, we can pick it up on the ECG. Or if the patient has got hypertensive heart failure, we know that we have evidence of left ventricular hypertrophy or other arrhythmias, which can also give us clue that this patient is likely to have a cardiac failure. So ECG is a very important bedside test. The other important bedside test is an echocardiogram. I think any patient who gets admitted in the ICU needs to undertake a testing of echocardiogram, which is a simple bedside test and available in practically every small nursing home, every small hospital, but it gives you wealth of information. So when you do an echocardiogram, you are able to distinguish between systolic heart failure, between diastolic heart failure, what is the etiology, whether patient has got regional wall motion abnormalities, you know that this patient has probably an inferior wall infarct or a whole anterior wall infarct. Doppler studies on echocardiography will help you in assessing the presence of either leakage of the valve or stenosis of valve, either mitral stenosis, aortic stenosis, or severe MR or severe AR, or whether there's evidence of pulmonary hypertension which is causing right side failure. So echo is a very important test which helps us in differentiating between systolic heart failure, diastolic heart failure, and the cause etiology of heart failure. X-ray chest, again, important bedside test, should be done for all patients who get admitted to ICU. A large heart would tell you whether the patient got a dilated heart, or a rounded heart would also tell you whether this patient has got an additional pericardial effusion. Presence of lung congestion in terms of severe venous lines can tell us whether this patient has got elevated left ventricular and diastolic pressures. Nowadays, cardiac MRI has come in a big way to decide between. It helps us in finding out the etiology of ischemic heart disease. In many cases of amyloid heart disease or in case of sarcoidosis, we're able to pick up the diagnosis. We no longer require invasive tests like a cardiac biopsy to establish the diagnosis. A cardiac MR gives a lot of information regarding the type, etiology, and the type of heart failure. So these are, in fact, just 2 days ago, I had a patient who came to me with a extensive anterior wall infarct. And he was thrombolized and he was in pulmonary edema at some other place. Came to me for an opinion. I examined him. I still found him in mild failure. Gave him I gave him anti-failure treatment, and his echo was showing that EF was about 20-25%. But I was not aware whether there was a viable myocardium or not. So we sent him for a PET scan, which gives us perfusion studies and viability of myocardium. The PET scan surprisingly showed a lot of viable myocardium. So this patient had a proximal LAD, viable myocardium, and he had two large vessels coming from just across the ostium of the LAD. So therefore, it gave me an idea, insight, that this patient will benefit by bypass surgery despite having an infarct, despite being in pulmonary edema, and despite having a low EF. Post-operatively, I expect him to do well. So today, investigations not only help us in establishing a diagnosis and etiology of heart failure, but it also helps us in assessing the prognosis in future of how the patient will fare after an invasive procedure has been done. So these are the various investigations which are available. And patients with heart failure, we should not do a stress test because that could precipitate problems and it could be dangerous to life. So these are the non-invasive tests which are available for investigations and assessing the prognosis of the patient. Now, once you have established a diagnosis, last time we had discussed about diastolic heart failure. Today we are discussing about systolic heart failure. There's a graded way of managing these patients. The first drug of choice is you start off with diuretics. Diuretics can be either simple mild diuretics or they could be strong loop diuretics like Lasix or furosemide and torsemide. Torsemide is a much more powerful diuretic than furosemide. So depending on how severe the failure is, we can decide about adding diuretics. Aldactone, which is a spironolactone receptor activist, this has been found to be useful in not only causing diuresis, but also helps in improving cardiac function. So first is reduce the fluid overload and thereby, depending on the extent of failure, decide on mild diuretics or a little more stronger diuretics. Sometimes you may have to use a combination of both loop diuretics as well as spironolactone. The second group of drugs which are very useful is ACE inhibitors. In fact, today we have more trials and more data on combination of sacubitril valsartan, which the original drug is Vimada or Sidbus, which are now locally available. This is not only helps in improving the diuresis, but it also helps in improving cardiac function. The earlier generation ACE inhibitors like olmesartan, losart, they're also useful, but combination of sacubitril and valsartan has been found to be more superior in reducing in patients with heart failure. And this combination is also useful in diastolic heart failure. The next group of drugs is beta blockers. Beta blockers reduces the heart rate, improves the contractility. In fact, when the patient is in fluid overload state, beta blockers should not be started. So it's very important that first you dry up the patient with diuretics, ACE inhibitors, then subsequently go on to beta blockers. Beta blockers should be started only in the state when the patient is already dry. That time beta blocker the effect of beta blocker is enhanced and it helps in improving the cardiac function, reduces the oxygen consumption by reducing the heart rate, and that is how beta blockers is beneficial. In fact, one more newer group of drug which is now added is dapagliflozin. Dapagliflozin is in fact a class 1A indicator for patients with heart failure, and it should be added as a first line of treatment in patients with systolic heart failure. And it can go anywhere between 10 to 40, 50 milligram per day, and that is So it is not only a, a drug for heart failure, but it also helps in improving the metabolism and helps controlling the diabetic status of the patient. And if after adding these drugs, if the patient still does not have improvement, he still continues to remain failure, one may introduce digoxin. Though digoxin is a time-tested drug, literature does not keep it as a first line of treatment, but it has its role to play and can be useful in patients who have otherwise uh, poor cardiac function. If the patient still continues to remain in refractory cardiac failure, it is very important to assess whether this patient has got iron deficiency. Iron deficiency is a subtle cause, or anemia is a subtle cause for systolic heart failure. And correcting the anemia by giving either iron infusion or giving oral iron supplements to build up the hemoglobin to 12 to 14 can help in controlling refractory heart failure. So these are the drugs which are useful in controlling patients with systolic heart failure. If in addition the patient has LV dysfunction and the patient has left bundle branch block, then we will go to the further line of management. So these are the pharmacological management of patients with heart failure. Then we have non-pharmacological non-pharmacological methods to control heart failure. Lifestyle, regular diet, a proper diet is very important, and a diet which gives you a combination of elements of proteins and restrict the amount of carbohydrates in your diet. Restrict the fluid intake. I think the fluid intake restriction is very important. Maybe to less than 1 liter per day, though it is easier said than done, but I think it's very important. And regular weight management. The moment you find that your weight is increasing, you know that you're retaining fluid, and you should do every which way to avoid retention of fluid and control your weight as far as possible. Excessive weight is one of the obesity is one of the additional risk factors for patients with systolic heart failure. Smoking, as I mentioned earlier, cessation of smoking is very important. So lifestyle modification, in fact, forms a very important aspect of management of systolic heart failure. Cardiac rehab, structured program for physical and psychological support. I think a lot of data is today available where there is a direct connection between the mental health and the gut health, the overall physical well-being of an individual. So controlling psychological factors, giving positive affirmations, and giving assurance that patient will do well, very important, because it's the mental state of a patient which helps him to recover faster. Gut health is equally important. Giving diet which helps you to improve the good gut bacteria are extremely useful in controlling overall well-being of the patient. Now, if this patient also has an additional problems like he's got LBBB, then devices would help. And we have seen with the use of CRTD or CRTP, which is a combo device, the ventricular function can improve from as low as 25-30% to almost 45-50%. So devices have come in a big way to improve the cardiac function. And if the patient has got arrhythmias, then probably we may have to have the combo device with a defibrillator, CRTD. So depending on what is the arrhythmia, what is the level of block, if we use these combo devices, these patients are known to benefit with devices. Prognosis and future directions. I think early diagnosis of heart failure is crucial for better care and improvement and better outcomes in this patient. Each patient needs to be individualized. You cannot start a blanket treatment for every patient like this. Depending on what are the risk factors, what are the etiology, patient obese, get the get the weight down as early as possible, keep the blood sugars well under control, get the blood pressure well under control, psychological. So every treatment has to be individualized to every patient. And novel therapies are newer and newer therapies are coming for patients with heart failure. I think the future is very bright. We now also have something like gene therapy, which is coming up, or stem cell therapy, which is coming up for cardiac failure. And in case if all failures, if despite all the therapy, if the patient still remains in cardiac failure, then we today have an option of keeping the patient on ECMO as a bridge to transplantation. Cardiac transplantation is coming in a big way. However, we do have quite a few centers doing cardiac transplantation, but the cost of therapy is quite costly and only few selected patients can afford. So, dear friend, we come to the end of this talk, and if there are any questions, we can take the questions. The basic idea was to enlighten you on systolic heart failure, the therapies which are available, and how we can go ahead and treat the patients with various drugs which are available today, and the newer devices, newer therapies, which the future is very bright for patients with heart failure. Last time I discussed about diastolic heart failure. Today I've discussed about systolic heart failure. It is very, very encouraging. The various treatment, newer drugs which are available. I think at your level, probably devices may not come in, but my talk would have enlightened you on handling the basic patients with heart failure. You can prevent at your level. What you can do is pick up the cases early, prevent admissions to hospital, and thereby improve the quality of life of the patients. Any questions if anyone has?
May I ask question, sir?
Yes, please, Suresh.
What are the early signs of heart going into failure?
See, the
Systolic failure.
early signs.
Or
PND,
symptoms.
PND.
The early signs of patients' heart going into failure would be the patient starts getting, if
PND.
first is dyspnea. If he starts getting breathless or doing unusual activity, he should suspect that probably there's something wrong. If you have the patient coming with mild edema of the feet, you should suspect whether he's going in for failure, or if the patient is unable to lie down at night, he has to get up. He develops PND at night. These are all early indicators of patient going into heart failure. And you can supplement it by doing basic investigations, like get an NT-proBNP done. If you have an elevated NT-proBNP with mild symptoms of cardiac failure, I think it'll help you in picking up patients with heart failure very early.
Is there any ECG changes during that period?
Pardon?
Is there any ECG changes?
No, you may not have ECG changes, especially if you have diastolic heart failure. You may not have any ECG changes at all. Even a patient with diabetes and diffuse disease, there may not be. There may be just subtle ECG changes. So I don't think ECG is a great marker for picking up heart failure, early heart failure. But NT-proBNP or a TROP-I which is elevated would be early markers for heart failure.
Suppose if you visit at night times in somebody's house and he is in a failure, what GP can do it at their home?
Yes, I think that's a very, very good question. One is in your kit, when you're going home, you should carry certain drugs which would help you in treating the patient at home. Number one is, if you can give a propped up position to the patient, that would help. Because a propped up position will reduce the venous return to the heart. Number two is, if the patient has oxygen cylinder or any which way by which he can be given oxygen, please give him oxygen. Number three is giving him diuretics at home. Either you can give him a small dose of Lasix. See, you need to monitor the patient's BP. if the patient's BP is elevated, then you can give him a fairly good amount of diuretics. That will help him to redirect the fluid congestion from lungs to his, he'll be able to pass out the urine from kidney. And give him an aspirin for whatever it is, because if it's a ischemic problem which is giving rise to this problem, giving rise to heart failure, aspirin will help in to its antiplatelet activities. And if you have a nebulizer, if you can nebulize him, or you can ask him to take a inhaler, because dual stimulator, beta stimulants, they also are known to reduce heart failure. So,
Okay.
bronchospasm, if you relieve it, if you give him diuretics, give him a proper position, and if you give him aspirin, I think that will help you tide over the crisis immediately until he reaches a hospital where further management can be done.
See, I had one important patient who went for stress test. After stress test, he came home. He wanted to save the money. He went to some center. He got it, and he went into breathlessness and coming up fogging, and went into failure.
Very unfortunate. See, I think I would tell you, the protocol done at my hospital. Number one is when the patient comes for a stress test, we take a proper history of the patient. We document the entire history. What is the past history? What are the drugs the patient is taking? And we monitor the hemodynamics of the patient. Number one. Number two, all the stress tests are performed under a supervision of a cardiologist. I think it's very important that there should be a well-trained person in managing. Treadmill should not be taken lightly.
Because there are schemes available on the online, and he went there in spite of note was given to the cardiologist.
No, I think a stress test is something which can cause sudden death on the treadmill itself while doing the treadmill, or you can push the patient to failure. So it's very important that they just, because of the schemes, they just walk, humko stress test karna hai. But I think a proper evaluation before you put the patient on treadmill is very, very important. Because if it's not a qualified person who's doing it, then you are likely to burn your finger sometime.
Thank you, sir.
In fact, I'm very happy all of you have attended. But we would like to, from next month, we are now extending our Guru Vidya program to districts like Jalgaon, Dhule, Buldana, and by the end of the year, we'll be all over the state. So,
It will be
as
good.
friends, I would like to invite any feedback from all of you, so that we can keep on improving on the topics, on the quality of matter that we give, and keep it down to your level so that you all benefit in your management and patient outcomes.
It was a good idea, sir. I tell you, there are people practicing at periphery. They don't have CME. They don't have any consultation.
Yes.
And I find it they are very difficult to how they are managing. I don't know.
Suresh, we are not only thinking of reaching out to all Maharashtra, but we are planning to go to pan India. See, like Northeast, especially Assam, Vagare, that area, medical treatment is woefully lacking. Jammu and
Yes,
Kashmir, it is lacking. So, as a tribute to our teachers, we would like to share our education with all of you. And if we can contribute to improvement in medical care, I think that is the dakshina which I can give to my teachers.
so good idea, sir.
Thank you so much. Thank you.
Okay, thanks a lot, sir.
Irfan, anything?
सर बहुत अच्छा लगा, बहुत रिफ्रेश हो गया सर थोड़ा। सर मैं क्या बोल रहा हूँ कि ये जो आप बोल रहे हैं कि मैं हर जगह जाना चाहता हूँ, सर ये लोगों के पास आजकल पैसा बहुत कम हो गया है सर, तो उसके लिए कुछ करो ना सर, चार्जेस वगैरह ऐसा कुछ कम हो जाए तो उनको फायदा हो जाएगा। क्योंकि मेरे डिस्पेंसरी पे आते हैं ना सर, बहुत ही तकलीफ में रहते थे।
Irfan,
हाँ
our hospital has taken up the scheme patients, government scheme, Mahatma
हाँ
Jyotirao Phule.
हाँ वो मालूम है सर। हाँ
So in the scheme patients, the bypass of the patient is done practically free of cost. Angioplasty is done free of cost.
नहीं, मैं कंसल्टिंग की बात कर रहा हूँ सर, जैसे कंसल्टिंग
Consulting
वगैरह।
also, for scheme patients, we charge 50% of our regular consulting charges.
अच्छा
Yeah. So we are here to help people. Our passion is to help people, and
हाँ वो
especially
तो मैं
middle class people.
वो तो मैं जानता हूँ सर पहले से आपको सर आप फिलांथ्रोपिस्ट है सर आप
No.
बहुत
I
दिल
think
के बड़े हैं सर
God has given us life to make a difference to mankind.
हाँ सर सर हमें दुआ है कि अल्लाह आपको हमेशा अच्छा रखे
Thank you so much. Thank you so much.
हाँ
So we will come to the end of this session. Thank you so much for attending this session. We will continue this as a lifelong program once a month. Right now, once a month, but subsequently, I think if the numbers are more and the request is more, then we may even come once a week.
यस
Okay.
ओके
Bye. Thank you so much.